Hi, welcome to a trauma-informed care presentation as part of the Athletic Female Health Foundational Course Series. I will be your presenter. My name is Elizabeth Bird, and I'm a former athletic trainer who has now turned into a mental health therapist. So a quick overview of what we'll be going through is an introduction about myself, my educational background, and why I feel like I'm prepared to present on this information. Going into the definitions of ACEs, trauma, and healthcare, and really identifying what trauma-informed care is, and then how to become a trauma-informed clinician as an athletic trainer, and then we'll be reviewing what we've talked about today. So a little bit about me is that I received my Bachelor of Science in Athletic Training from James Madison University in 2014. I was an athletic trainer for 3 years before deciding to go back to grad school, where I got my master's at California State University, Northridge in 2019, focusing on kinesiology and sports psychology. I did my master's thesis in athletic identity and transitioning out of college sports. And while I was there, I was a graduate assistant athletic trainer working with softball and women's soccer. And I really found a passion in the mental side of healing. So I knew that long term I wanted to transition into a mental health therapist. And in 2020, I decided to take that leap where I moved to Utah to really explore what it meant to be in the mental health field, working in eating disorder treatment centers, substance use centers. And then I got my master's from the University of Utah in clinical mental health counseling, graduating last spring. I'm currently a therapist at the University of Utah in their athletics department, working with their swim and dive, ski, and cross country teams. So I'm able to stay embedded with athletes, really focusing on mental health and mental performance. So to get started, I want to just review some statistics when it comes to trauma and trauma-informed care. So what we do know is that 1 in 10 children are reported as potential victims of child abuse or neglect annually. About 3.6 Americans are currently living with PTSD, which is post-traumatic stress disorder. And at least 64% of adults have reported that they have experienced at least one ACE before the age of 18. And an ACE is an adverse childhood experience. We also know that more than 80% of first responders experience traumatic events on the job. It's important to recognize your job as an athletic trainer and the role that you play in being a first responder. And so experiencing trauma either firsthand or as secondhand is something to really be aware of in this profession. First, we'll get started with some definitions. Trauma really refers to the experiences that cause intense physical and psychological stress reactions. So it can either refer to a single event, multiple events, or a set of circumstances that have been experienced by an individual as physically or emotionally harmful or threatening, and that has a lasting adverse effect on the individual's physical, social, emotional, or spiritual well-being. Trauma is not always the act, it is how we respond to what happens to us. So really thinking about how we respond. Two people can experience the same exact thing and have different responses. So that does not mean that everyone who has experienced a traumatic event will have PTSD. ACEs stand for Adverse Childhood Experiences and are potentially traumatic events that occur in a child's life from birth to age 17. Some examples of ACEs are experiencing violence, abuse, or neglect, witnessing violence in the home or community, having a family member attempt or die by suicide. There also included aspects of the child's environment that can undermine their sense of safety. And so what that can look like is substance use problems in the home, mental health problems by a caregiver or another family member, or instability due to parental separation. What does it mean to be trauma informed? Really, that includes an understanding of trauma and an awareness of the impact that it can have across settings, services, and populations. It's a foundation to understand that trauma affects every individual differently and that it can be not only an individual experience, but a community experience as well. Trauma-informed care is a strengths-based service delivery approach that is grounded in an understanding of and a responsiveness to the impact of trauma that emphasizes physical, psychological, and emotional safety for both the providers and the survivors. And that creates opportunities for survivors to rebuild a sense of control and empowerment. So, something to really think about is how you can be a trauma-informed clinician taking on a strength-based approach as an athletic trainer in any setting that you're in. There's different types of trauma. There's trauma that can be caused naturally, such as a tornado, a lightning strike, a wildfire, avalanche, flood, hurricane, landslide, any natural disasters, and also an epidemic, which is something that we have all experienced. There's also types of trauma that are caused by people. There's accidents and intentional acts. Accidents and catastrophes are things such as train derailment, structural collapse, car accident, oil spill, machinery related accident, or a sports related death. Intentional acts are arson, terrorism, sexual assault or abuse, homicide or suicide, mob violence, physical abuse or neglect, home invasion, domestic violence, human trafficking, or school violence. Considering the differences between accidents that are caused by people and then intentional acts that are caused by people, we might experience these as athletic trainers, looking at the sports-related death, school violence, even sexual assault or abuse or physical abuse or neglect. You might be working with adults or children, and it's really important to be aware of this. Screen. So why is it important to have an awareness of all of these definitions? Well, it's important because it creates an awareness, which is what it means to be trauma informed. You don't know what you don't know. And childhood experiences affect how you show up in your life as an adult and throughout your life. It also allows us to engage in compassion with our clients and our athletes and patients. So we move from what is wrong with you to what happened to you and opening up that scope with curiosity and openness. We're going to start off with our first question, which is, what is trauma? A, physical abuse. B, experience that causes intense physical and or psychological stress reactions. C, experiencing a natural disaster. Or D, not having a loving home. The answer is experience that causes intense physical and or psychological stress reactions. Again, trauma is not the act itself, but the response to what has happened to us. Question number 2. What is an accident caused by people? An epidemic, school violence, terrorism, or a sports-related accident? The answer is sports-related. While an epidemic might have been an accident caused by people, it is more of a natural disaster than it is an intentional accident. School violence and terrorism are both intentional acts caused by people. Why is trauma-informed care important as an athletic trainer? Well, research suggests that PTSD and or problem drinking is evident in nearly 50% of patients 1 year after discharge from trauma surgical units. Now, while you may be an athletic trainer who works in a hospital setting, you might also be an athletic trainer who works in a clinic, in an industrialized setting at a high school or at a college, or even with a professional sports team. And it's important to recognize that trauma surgical units, we might have to engage with them if we send our athletes off after a catastrophic injury. So our athletes might be experiencing PTSD symptoms after experiencing a traumatic event on the sports field. We also know that acute stress disorder is prevalent among patients at medical trauma centers, and it's very high, making trauma-related disorders some of the most common complications seen in physically injured patients. Thinking about your job as an athletic trainer, you deal with patients and athletes who are physically injured. And so it's really important to be aware of how they are responding to that acute stress. Trauma-informed care really starts with these 6 principles: safety, trustworthiness, and transparency, peer support, collaboration and mutuality, empowerment and choice, and cultural, historical, and gender issues. The foundation of trauma-informed care is relational healthcare, which is the ability to form and maintain safe, stable, and nurturing relationships. As an athletic trainer, we are really tuned into how to create a relationship with our athletes and our patients and engaging in those micro skills. It's what we call it in therapy, of just engaging and creating a relationship with them. We know how to hold conversations outside of the injury itself. And so really leaning in on, we already have a foundation to be trauma-informed clinicians. We're going to create that with our relational healthcare. And it's also important to understand attachment and resilience when it comes to trauma. So attachment and resilience provide a backdrop for understanding how trauma and individuals respond to trauma. Attachment is an emotionally attuned give and take between caregiver and child, and the trust, safety, and security of the child that promotes healthy brain growth, development of an accurate sense of self and others, development of resilience, and protection from trauma. So if we grow up in a household where we have a disorganized attachment or insecure attachment, it can really make us more predisposed to engage to traumatic events in our life. And with that, we have people who have experienced traumatic events, have experienced trauma directly, and they can build resilience. That's really focusing on a post-traumatic growth outlook. And resilience is a dynamic process of positive adaptation to or despite significant adversities, which was really instilling hope, optimism, faith, belief in the future for oneself, regulation, self, ability to create secure attachments, and a sense that one can impact outcomes. We're going to come back to some multiple choice questions. So, what is the first principle of trauma-informed care? Is it collaboration, safety, peer support, or empowerment? The answer is safety. Safety is the first thing that we need to implement when it comes to taking a trauma-informed approach. And we'll talk more about this as we continue on with this presentation. Question number 4, what percentage of patients may develop PTSD symptoms after discharging from a trauma unit? Is it 30%, 75%, 50%, or 60%? And the answer is about 50% of patients may develop PTSD symptoms following a stay at a trauma unit. Trauma-informed approach when diagnosing. It's really important to recognize that this approach is really focused on diagnosing in the clinic or in your athletic training room. This is more for like when you're doing one-on-one individual care with them, really taking a full history, not so much of an on-field or quick evaluation before determining next steps. And it starts with detection and assessment of trauma, which really focuses on purposeful triage, engagement, history taking, surveillance and screening, examination, differential diagnosis, and sharing your diagnosis with your athletes or patients, and then management from there. Purposeful triage is really being able to differentiate between an emergency or a non-emergency. So when you're dealing with trauma, its consequences or causes, it's important to consider if the person is emergently at risk. And so when you've been doing a one-on-one assessment, this can be with a child or an adult, it's important to recognize the signs and understand, is this an emergency that I need to contact an outside agency to help with the health and safety of the person in front of me? And trauma identification, really focusing on trauma may result from unsafe settings because of abuse, neglect, or impaired caregiving. And it can also be from direct violence or discrimination. So, being able to understand if your client or patient is actively at harm, and when to contact an outside agency. If it is a current emergency, we need to contact Child Protective Services directly, and that could be through your DCFS, Department of Child and Family Services, at your local state, or even your local county. And then from there, it is important to then contact parents. Now, if you're concerned for the child's health and safety due to parental neglect or abuse, it is important to contact DCFS, and they might have you contact the police right away. You are a mandated reporter in, if not all states, but most states. And so learning your state laws around mandated reporting, because your number one priority is the health and safety of the athlete and patient in front of you. If it's an adult, you want to ask them if they would like to contact the police or another agency with you for assistance. Now, if an adult is engaged in a domestic violence situation, because they are an adult, they have the choice to really look out for those other resources. But we really want to focus on empowerment and collaboration with our athletes and our patients. So it's important to use active listening and motivational interviewing to help them focus, to help them create this sense of autonomy. And sometimes that is calling together because you're wanting the best for them. And it's really leaning on you're wanting their health and safety as your number one priority. Engagement is really focusing on engaging the individual and being fully present and balancing both professionalism and friendliness. So when we are doing a history taking or an intake, we are really focusing on being completely present with the person in front of us, stating, exactly what we're there for as a professional athletic trainer, but then also really focusing on that friendliness. And that involves active listening in a non-judgmental, attuned way. In a non-judgmental, attuned way is really nodding, giving them the body language that you are fully present and listening to what they're saying, and not giving your own judgments, but just reflecting back on what was heard for clarification and confirmation. And then if you're needing to, you can always seek clarification when necessary, asking, oh, is this what you were saying? I just want to make sure that I'm hearing you correctly. And that can look like asking them to clarify or asking them if that was correct in what you had reflected back. And then paraphrasing, attending to, and reflecting on emotions that accompany the information. So if you're hearing a whole story about what they're going through, really focusing on reflecting the feelings that you're hearing and paraphrasing what you've heard. Again, asking for that clarification so they can either change what you have said or confirm what you have reflected back to them. And last but not least, really summarizing what was discussed in that session. Sometimes it is just the injury, but sometimes you're given little bits of information in the history portion, and really focusing on summarizing that so that you can keep them aware that you are listening to them. If you're working with an adult or even a child and you suspect that there is some trauma that has been experienced or they are currently experiencing, it's really important to focus on the relationship and building that rapport so that when they are ready to disclose what's happened, they feel like they can come to you. When doing an evaluation, the biggest part is understanding history. And so you will identify the mechanism of the injury that's in front of you or the illness of what they're experiencing, and explore the history of the patient in front of you. A trauma-informed approach focuses beyond the injury or illness that you're seeing, and it looks at the person globally. So really looking at their social, developmental, substance use, mental health history, medical history, any risk for self-harm, suicide, or violence. Again, this is really dependent on your setting and the relationship that you have with your athlete and patient. If you're working in a clinic, you may be engaging in full history taking, and substance use or mental health history or medical history are part of it. If you're working in a high school setting, you might not have the time or rapport to really ask these questions, but listening to your intuition if you're concerned for their risk of self-harm, suicide, or violence, and really asking if there's been any incidences. The most common symptoms of trauma exposure that we've seen in children, and this can also be developed in adults, can be labeled as frayed. And so, really thinking about frets or fears, so anxiety and worry or fears, regulation difficulties. In children, this can look like disorders for behaviors or emotional dysregulation, hyperactivity or impulsivity, or they become easily aggressive or emotional or inattentive. Some of these things can also be seen in adults who have a hard time sitting still or being emotionally present, or their emotions do not reflect the situation at hand. Attachment challenges that can look like insecure attachment relationships with their caregivers or poor peer relationships. If you're working with an athlete in a high school setting or even a college setting, you might be able to see how this individual engages with their teammates or others and noticing any insecure attachments to friends or other relationships in their life. Yawning or yelling, so that could look like sleep problems or aggression and impulsivity. Sleep disturbances can be a sign that you have experienced trauma. It can also be a sign of just general stress, but it's something to be aware of. Educational and developmental delays, cognitive, social, emotional, or communication. And then feeling defeated, depressed, or disassociated, which looks like separated from reality of the moment. They look like they might be staring off, they're living in their own head. Again, you don't need all of these, and some of these might just be situational and someone has not experienced a traumatic event, but it's something to be aware of when you're doing a history taking. We've also known that IBS can be linked to trauma or generalized anxiety. And so thinking about digestive concerns as well, or chronic concerns for digestive problems if they're coming up consistently. Surveillance and screening is really the process of recognizing individuals who might be at risk for being affected by trauma or who have been affected by trauma. So that requires attention to the relationships and engagement that you see, not only with you yourself and the athlete or patient, but also with them and other people in the clinic or their other setting that you're in. Screening is more appropriate at a clinic or maybe an industrial setting, but when working in a clinic, you can use a screener to assess clients who may have experienced or are at risk for trauma. And there are trauma screeners out there. One of them is the PTSD checklist from the DSM-5, which is the diagnostic manual used by therapists. And then an examination. So always ask permission before you palpate or do any special tests if you're needing to physically touch your clients or your athletes. Really looking for any physical signs of trauma or abuse happening. And that could look like bruising, marks, and/or wounds that do not align with the injury or illness that you're evaluating. Flinching or reacting when needing to palpate or being aware of their caution. So if you're noticing an athlete or a patient really being on edge or hesitant and cautious around you, maybe be aware that they might have experienced trauma in the past and they do not feel safe with another provider touching them or providing care. And so always asking permission, really leaning into that autonomy and empowerment. And then some medical signs of trauma or even experienced a traumatic event could be elevated high blood pressure, not related to your injury or illness that you're evaluating. When we know that overweight and obesity have been associated with ACEs, I want to reiterate that when we're looking at this from a trauma-informed lens, not one of these things means that someone has experienced trauma in their life, but it helps provide a whole picture when we're assessing an individual. So again, we're thinking globally. Just because someone has a bruise does not mean that they are experiencing physical abuse at home or domestic violence situation, but it's important to be aware and ask questions. We always want to create a differential diagnosis. I learned this from my team physician when I was in undergrad, but really looking at things locally, regionally, globally. So starting with locally, right? When you're diagnosing an injury or illness, you want to start with the injury itself and then move outwards. Why is this important? Well, because physical and emotional symptoms can be related to a traumatic event. The experience of trauma and adversity is very common. And the symptoms of trauma overlap with symptoms of other conditions, such as irritable bowel syndrome, headaches, chronic pain, sleep disturbances, overuse injuries. And a failure to do so and thinking globally, it may result in an incorrect or incomplete diagnosis or treatment, or even your athlete or patient not getting the care that they need. Management really starts with the concern for acute safety, like we said before, identifying if it's an emergency or a non-emergent situation. But you always want to share your plan to disclose concerns to the child, to Child Protective Services and parents. So if you're notifying any outside agencies, you really want to let them know what your plan is and why you're doing this and bring them into it, leaning again on that collaboration and empowerment, and then reinforcing care and compassion towards your patients or athletes. I need to contact this outside agency because I'm concerned for your safety. And I know that it's really scary that I'm going to have to call them. So if we could call them together, I would really like to do this as a team. Does it always go the way that you want it to go? No. But it's better to call for concern than to hope that someone else calls and really lead towards that bystander effect. It's also important to think about concern for past experiences. So if you're, especially when you're working with an adult or even a later teenager, so 18 and older, really recommending mental health referrals and appropriate medical referrals if you're concerned for trauma or an adverse childhood experience. And then be mindful of how they present. Are they on edge, fearful, avoidant? Again, that doesn't mean that they've experienced trauma, but it may help paint a picture of how they're showing up or why they show up in certain ways for treatment and rehab. Okay, question number 5. What are common symptoms of trauma exposure? Lucid dreams, changes in routine, conflict, or sleep disturbances? And the answer is sleep disturbances. The conflict or changes in routine might also have been symptoms, but one of the more common symptoms for trauma exposure is sleep disturbances, and that can look like restlessness, difficulty falling asleep, difficulty staying asleep, nightmares, or even enuresis, which means wetting the bed. What is a medical sign of trauma? Heart conditions, diabetes, elevated blood pressure, or sleep disturbances? This one is actually kind of tricky because while the answer is elevated blood pressure based off of this presentation, there is some limited research that there could be a trauma-related condition with heart conditions or diabetes. While that might be some correlation, we don't believe that there is any causation. So those could also be answers as well, but based on our presentation, it is elevated blood pressure. And then sleep disturbances, while that is a sign of trauma exposure, one sign of trauma exposure, it might not be a medical sign. And then question number 7, what do you do when a child discloses abuse? Now, this is for the individuals who are working in the secondary school setting, as you are likely a mandated reporter. And if the child is 18 and still living at home, you can call. Now, it might depend on the state of what they do, but if they are still under the care of a parent, it is important to contact DCFS or Child Protective Services and make that referral and make that report than if you were to not say anything at all. And so what do you do when a child discloses abuse? You call local services, DCFS or CPS, call the police, contact the child's parents, or just listen and offer compassion. Well, I kind of gave away that answer in the first part of this. So you want to call DCFS and CPS. Now, once you call them, they actually might have you call the police if they're concerned for the safety right then and there, or a parent is actively threatening their child. Now, if you're doing this evaluation in front of the child without a parent present, you might have to contact the parent, even if they are or are not involved in the abuse that was disclosed. And you always do want to listen and offer compassion, but ultimately you're concerned for their health and safety. And so you will need to report this so we can make sure that the child is safe. And by child, I mean adolescent, and really ensuring their overall safety. How do we translate a trauma-informed approach when it comes to diagnosis into treatment? I actually think that this part of the presentation will probably be the most utilized piece as an athletic trainer. We're going to remind you of the 6 guiding principles when it comes to a trauma-informed approach. And that starts with safety, creating a trustworthiness and transparent relationship, peer support and acknowledging what that is for the athlete or patient in front of you, collaboration and mutuality, empowerment and choice, and then understanding cultural, historical, and gender issues. So in rehab and treatment, we really want to make sure that we have created a space that feels physically and emotionally safe. We cannot prevent triggers from happening in the world around us, but what we can do is ensure that the space is set up to be physically safe and emotionally safe. And that means that we treat people with respect and care. Trustworthiness and transparency. Really be aware of how you interact with this athlete or patient and continue to ask permission when evaluating and providing treatments. So you want to be really transparent about what your goals are. And whenever you have a rehab plan, you really want to make sure that you're creating that trust. And that trust starts with being transparent with them. You know, you will be out for this amount of time. This is what I'm concerned about. Do you have any questions? Really asking for clarification so that they can ask you questions and they feel that they can trust you when they have a question or a concern. With peer support, it comes from understanding how they interact with their peers and, when appropriate, guiding them to lean on peer support. So if we notice that they're really isolating, how can we help them feel incorporated and part of the team? And if they are isolating, what has happened that feels out of the norm for them? When it comes to empowerment and choice, we really want to highlight the strengths and resilience when appropriate with this athlete. So if we see them coming in every day, doing all their exercises, that'd be amazing. Really highlighting that strength of theirs. I love that you're so tenacious in here and you're really trying to be a go-getter. I've seen you bounce back from this injury, and that shows a lot of resilience and being able to manage adversity. And then use rehab as space to increase autonomy and collaboration. How can we make them a part of this process so they feel empowered and they feel like they have a choice in what they're doing? That comes with letting them know, hey, this is where we need to go with this exercise. Maybe that gives them 2 options of the same exercise that you're wanting them to do, and they can choose that one. That builds that resiliency, that autonomy, and sense of self for them. And then leading with cultural humility. Understand that the athlete or patient you treat holds so many identities, and being a culturally competent clinician is leading with cultural humility. And that really means that understanding that all the identities that they may hold, race, ethnicity, religious affiliation, sexuality, gender, socioeconomic status, all of that affects how they engage in the world and how they show up in the world. And that some of those identities that they hold may be marginalized, which may make them more susceptible to discrimination or experiencing a traumatic exposure or event. And so really understanding the athlete that you have in front of you, again, as a whole person. So not only looking at their injury locally or even regionally, okay, they're a teenager, but who are they globally? What are all the identities that they hold? And then finally, really knowing your scope of practice. Like, you can be compassionate and set boundaries. I think as an athletic trainer, like I said before, you're really set up to develop that relationship with your athletes and your patients. And so a lot of athletes and patients feel comfortable talking to you about experiences that could have been traumatic or maybe even feel traumatic when you hear them. And so continue to lead with that compassion and that care, and set boundaries for yourself and for them to be able to know what is appropriate to bring up in the athletic training room, in the clinic, and what needs to be brought up in therapy or with a mental health professional. So always offer care and compassion when they're sharing their feelings or their experiences. and then reminding them of how you can care for them as an athletic trainer and how seeking professional help can be beneficial. So this is what I can provide you with as an athletic trainer. I can provide this care, this support. And if we're really wanting to be able to move through this, you will need to seek professional help. And that comes with having a list of resources to refer your athletes or patients to. That can be a list of local private practices, the local community resource center that could look through the hospital or even just other community agencies, school counselors if you're at a high school or even a college, and if you're working at an institution or through a hospital setting, involving the hospital social worker and creating a disciplinary approach, an interdisciplinary approach and treatment team. Okay, question number 8. What is the goal of treatment with a trauma-informed approach? Understanding, empowerment and collaboration, helping your athlete process their trauma, or just create a rehab plan and treatment? The answer is empowerment and collaboration. So when you obviously you want to create a rehab plan and treatment plan with your athlete or your patient, but when really taking on this trauma-informed approach, we want to bring in that empowerment and collaboration. How can we make them a part of this process as opposed to just being a person who's told what to do? And it is not your job to help them process their trauma. However, you can offer understanding. At what age can you experience an adverse childhood experience, an ACE? 0 to 10 years, 0 to 17 years, 3 to 14 years, or 5 to 10 years? Now, this question goes way back to the beginning of our presentation, really thinking about adverse childhood experiences. And the answer is 0 to 17 years. It is from birth until you are considered an adult that you can experience an adverse childhood experience. And our last question, what is the first part of engaging with your athlete or patient? Is it active listening? Is it reflecting back for clarification, summarizing, or seeking clarification? The very first part when you're engaging your athlete with a trauma-informed approach is active listening. Active listening looks like you are intently engaging with them in the process. That is eye contact, nodding, any small verbals, yes, reminding them that you are listening to what they're saying, facing towards them. That is the first and foremost part so that they feel seen and heard as a human. To review, really trauma-informed care is relational healthcare. It is the foundation of being a trauma-informed clinician by treating each athlete or patient as a whole human and focusing on the relationship to help guide your treatment and rehab and future evaluations that you might have with this athlete or patient. And then really reminding yourself of the 6 guiding principles of trauma-informed care, which are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and then cultural, historical, and gender issues. So really looking through things with cultural humility. Thank you for listening to this presentation. Again, my name is Elizabeth Bird. I am an associate clinical mental health counselor here in Utah. I also am a certified athletic trainer, and I'm no longer practicing, but I still have a passion for this profession. If you have any questions, or if you're curious about how I've taken this path or how you can bring a trauma-informed approach to your clinic or setting, please reach out to this email, elizabeth.bird@utah.edu. Thanks.